Hi, everybody. Thank you so much for joining. We'll get started here in a couple of minutes, a little after 5. But we're excited here to be with you all and share some really cool information regarding ECLS and ECPR. All right. We are going to go ahead and get started. I want to thank everyone for joining us today with our ECLS 360 webinar series that we are starting back up for the year of 2025. Our first one for the year is on ECLS and ECPR and bridging the gap with emerging trends. This seems to be one of those hot topics that we're seeing a lot more of as we continue to move through our extracorporeal trends and everything that's emerging, all of the new equipment, technologies. It's getting to be crazy, especially, I know nobody wants to hear this, PTSD at its finest, but after COVID, I don't know about y'all, you can post this in the chat too. There's a questions box and there's also the chat box, but we had a lot more at the center that I manage in West Virginia. Well, I don't manage anymore. Actually, the ECMO coordinator's on. He's phenomenal. But we had a lot more VA recently than we have seen in the past with the cardiogenic shock patients and all this emerging, that we started our own ECPR program because we continue to grow with the status of, infancy all the way up to, 5-6 years down the line. So it's kind of cool watching all of the staff and the units from where I used to be grow with that program and begin to engage in all of these new emerging trends. And I'm sure a lot of you have those experiences, so we're excited to talk with you all about that. Our webinars, if you're not familiar with the style of them, are very informal. We like to talk and engage during them. We ask questions throughout them, so please, post in the chat, post the questions, post any comments that you have or any feedback, anything you can give back to any of us on here that can help us with our own programs and be able to lead them to the areas of success where weaknesses could be. It's much appreciated. Let's see if we can get this to work. So just a quick list of to do. Again, we have the designated box for any questions. Missy Grayson's on the line, so she's going to help us with being able to walk through those and make sure that we're answering everything. Please put comments in there too, like I had said, because a lot of you have more experience than I know that I do. We have Justin Henson, who's going to give an awesome presentation. He has an experienced ECMO center that does ECPR, and he's the coordinator of that center and has helped really build that program and bolster it up. But we're going to pause throughout the entire presentation to do some Q&A, and then obviously Q&A at the end. So again, please feel free to post all of that in the chat respectively. So our first question, if you want to post this, if you do have an ECPR program at your facility, what was your biggest barrier in getting your program off the ground? And I can't help but wonder what each person's biggest barrier is, because I can speak to our own, which I'll touch base on here in a minute. But it'll be interesting to see how everyone's could possibly be different from different perspectives that are seen. So just looking at a review of ECPR, some data, and how those programs are easily set up. Back in the pre-1990s, that's where we saw the foundations and the ideas of even ECPR being something that could emerge and be, of favor for patients that are in need. And then when we got to the 1990s, we had a lot of early case reports that were coming out down the line. But however, because we had that less advanced technology, when I graduated perfusion school, which I'm not going to say how long it was, because then it would give away my young age. But I had to walk around with an S3, like a full perfusion system, essentially, that's utilized in the OR. And that was our ECMO pump. So I cannot imagine, racing through hallways and trying to get patients on as fast as possible, which we did anyways. But in this situation, in the environment that we're seeing now with ECPR, with an S3 pushing it around, that actually flipped me all around the hallways with it. It was very insane. But the delays of getting that patient on, even from a team's perspective, and having good understanding with what we're trying to do as far as ECPR is, and again, that less advanced technology, really hindered. But it still gave us case reports that we could work from and build off of for the year when we approached the 2000s. And popularity with ECPR began to grow because we saw more improved technology. We saw systems getting smaller, easier to carry. We saw faster deployment of it. Teams were being trained better. We had simulations being built. More data, more research was coming out down the line. So, it's crazy how time continued to fly and all of that tech continued to go. But at the same time, if we fast forward, we saw things happening outside of the hospital, which got even crazier for us. And I don't know if you all remember this when they did the ECPR cannulation at the Lou, and the program at SAMU de Paris was established in 2011. It was designed to allow the ECMO and ECPR availability by a second line team. And this second line team became its own mobile care unit. It was the only, group that performed this. They were trained for it. They had 24/7 availability. It consisted of a nurse, anesthetist, sorry for that typo, an intensivist, an ER physician, a nurse, and a paramedic. The beauty of it is that early implementation in 2015, that team systematically dispatched any witnessed cardiac arrest. So once someone saw witnessed cardiac arrest, whether they heard it over the radio or anything like that, that team went for it full throttle. And then in 2016, I think it was actually 2017, that's when we saw that cannulation at the Lou, and they were able to bring that patient back. I don't believe, and someone in the chat can probably speak to this a little bit further for me, I don't believe that patient actually survived long term. However, it was still just very, alarming to see that a patient or, a visitor at the Lou was looking at this awesome painting, collapsed. A nurse that was a bystander, I do know that part, started chest compressions right away with the security help there. And we were able to put that patient on ECPR effectively with this small team that started in 2011. And just by these dispatched witnessed cardiac arrest was able to get that patient on ECMO and back to their hospital. So where do we even begin to think about these type of things? So, you really have to build your question when looking at an ECPR of why we're even starting it. Are you a regional referral center? Is it like a hub and spoke style program where you're the main hub and you have this massive trauma center and your ED is getting slammed with these ECPR calls or, CPR calls that patients would benefit, and your community needs are there? Are you already conducting ECPR like cases at your hospital, but you want to continue to improve on that and improve those outcomes? A lot of facilities, especially in the pediatric world, there are already ECPR programs, whether you like to admit it or not, because we're putting a lot of those cases emergently on ECMO from a PEDS perspective. There's a lot of adult cases that randomly pop up here and there throughout each year that are CPR-like, and we're putting them on ECMO as well. So it's just calling your program that and building it in the right perspective. Are there gaps? Are we seeing gaps in between areas like I just talked about that you could improve upon that would help bolster your community or even your patient population at hand? So those are different things that, when you're just starting out to look at. In the 2010s, we moved forward even further and we saw utilization of it more. We saw data and research coming out down the line. So if it's like a newer program and you're trying to figure out why you even want to start this, go back a little bit in time and look at why they perhaps might have utilized ECPR. What data and research did they start to look at that bolstered their idea and made them come out and want to go, you know what, this sounds like this could be something that could be really helpful for our patient population, our hospital, our community, etc. And then in the 2020s, we started to see all these even more so continued advancements with technology just getting smaller. Again, like I had said, pump disposables being integrated and smaller, the ability to carry everything. I know that even with the Abbott CentraMag, and I would have to do a transport, you'd have, both consoles and motors everywhere. It just got a little bit arduous and hard to really think about even functioning and taking those out into the field or on a football field or in the woods or however it would be. But the ability that we can learn from the best, like the team in Paris who started in 2011 and moving forward now, it gives us that ability to look towards the future of what is to come. And Dr. Dalton, who, I'm sure she'll jump on later, but one of the things that she said at a webinar that we were giving was, the future possibilities of ECMO at home. And everybody always laughs and goes, okay, LOL, like that meme that I have listed there, but you just never know. I'm sure a lot of people, including Gibbon himself, never thought that it would get to this area, or even Bartlett, never thought that ECMO would get to the stage that it is now over the period of time. So those are just different things that in the future, we really have to think about what those advancements and what that data and technology is going to eventually lead us to. And like I had said, that carrying capacity of these ECMO systems just getting smaller and smaller, the disposables being more compact and more streamlined. I had the bin full of tubing that you had to pretty much figure out and guess which piece went to what. Nothing was pre-connected, nothing was coded. So even having this type of technology available now makes it easier for that fast deployment. And when Justin talks, they use an older sense of technology, but they've really integrated it to make it easy for all to train on and use in that sense also. So sometimes this newer evolving technology with all the bells and whistles and gadgets, they're wonderful at the bedside, absolutely wonderful, and they're great for data collection. But, as you'll see when Justin speaks, sometimes you don't really need all of those bells and whistles when it comes to an ECPR style of program. I just wanted to touch base on a quick data review. Looking at ELSO, and one of ECLS 360 arms is the Orem clinical data analytics that we can utilize to compare some things. So according to ELSO's live registry board, which if all of you haven't had the opportunity to work with it yet, they just released a new registry platform, which is phenomenal. So make sure to check it out. But as of March 25 of 2025, the registry has documented a total of 247,000 ECLS cases, and among those, about 32,000 were categorized as ECPR, and that's distributed across different age groups. And I just wanted to break those down for you. So we're looking at neonatal at about 3,000 with a survival to discharge or transfer of 42%. Pediatric was showing almost 8,000 with a survival rate of 41%. And adult is 21,000 with a survival rate of 31%, which that adult ECPR with that case number and that survival rate, that's a lot higher than it used to be in the past. So we are coming a long way with our ECPR cases in the adult population itself. Or a smaller data platform collection, but it's growing substantially since the introduction of it. Our total centers, just looking at the year of 2023, was about 72 centers that put data in there, and they had about 540 looking at just the adults for respiratory, cardiac, and ECPR ECMO cases. And then in 2023, just looking at ECPR alone, that number jumped dramatically from 2022 to 2023, from 52 to 114. And then obviously in 2024, it remained on the higher end of 92. So again, all of these platforms that we're seeing from a data perspective and even from a clinical, what we're approaching, that ECPR case ratio is really going up in comparison to ECLS and overall standards as far as what hospitals are implementing and building upon. Going back to our program build, when you have all this data, you have all this research, you know that the technology is there for you, and you're thinking about those questions of why you even want to start an ECPR program, you now have to build that presentation, right? So we can all say, I want the Creamini ice cream maker by the Ninja because it's awesome, and I want to make sure that I have the best ice cream in the world, and I want to make it the best because my family deserves it. I need to make sure that I can present it to my husband because it's not exactly the cheapest item in the world for ice cream making. You could just go the old school, coffee can method where you're rolling it out. But in order to have that presentation and make sure that I can get what I want from this point of view, I need to make sure I'm showing him everything and why it's so important to me. And although this is completely different end of the spectrum itself, we just want to make sure that you have all of your ducks in a row when you're presenting this to your administration, because buy-in is one of the key components. You need to have a great team, and you need to have a team that's going to support you 1,000% behind this drive. And whether you are the MD that wants to present it, if you're a nurse that wants to present it, and you really want to build upon it as one of your projects, perfusion team, specialist, ECMO coordinator, it doesn't matter who you are within that hospital realm. You could even be a hospital admin and, CEO leadership who has no healthcare background, maybe coming down the line and saying, hey, you know what, I'm hearing about this everywhere. Is our hospital capable of doing it? And talking to the team and getting all of that information there that we just talked about, the data, the research, the equipment costs. What does that billing structure look like? What does your staffing look like? Are you going to have just a team that's designated to your ECPR program? Are you going to have training for that? What does that training look like? Are you going to use outside services to come in and help? Are you going to use ambulance services, helicopter services? The possibilities with this are completely endless. So starting off small, perhaps within your hospital, getting everybody on board, training your units, especially just in the way of how you're going to communicate all of this effectively, is huge. What about your patient selection also? Another big proponent, because we all know, more than half of you on the call know that we will put anyone on ECMO if we possibly could. Is it the right thing to do? Absolutely not. Is it something that does happen occasionally? Yes, it is. It's unfortunate. So from an ECPR perspective, setting up that criteria and laying that groundwork is huge. Not even just from, the pre-build component of it, but also looking at the resources perspective. So you can put anyone on ECMO, but let's say you have a max capacity of people you can put on is 3. You have 3 people on, you put all of them on, and their, outcomes are not as, you would hope they would be, but that's just the way the program was running. Your patient selection, could use some assistance and considerations. maybe different structure, but then you have that, 26-year-old patient who's ECPR and you're out of resources and you can't use them because you already have these 3 patients on who are probably going to be on for a significant period of time, or whatever the case may be. You just want to always make sure that that patient selection is good for your community, because I work in West Virginia, so our cohort of patients contain a lot higher BMI than most states might. So we have a different index as far as that's considered allowable for ECMO. But those resources are really important based off of where your geographic range is. You also want to make sure that pre-hospital, if you're going to be doing anything outside of that, what does that transport capability look like? If it's in hospital, what does that training look like for the units? And then obviously when you get them on ECMO, what does that continuum of care look like also for your team? Because you're going to have to do a lot more management look and evaluations for that patient. It's not just getting them on ECMO, making sure your cannulas are secure, doing a nice little x-ray of where the cannula placement is. You still have to do all of that, but then you might be going right directly to a head CT scan to see how the brain function is, what's going on there. There might be a bleed. What does everything else look like? And it's involving a lot more teams than you typically might see in a regular ECMO standard. So building algorithms such as these that help continue to educate that team, because ECPRs, although they might be, you might see like 10 a year, they might be very infrequent. They might happen once, 6 months later, you might see 3 or 4 in a row, and that gets everybody engaged. You might see one in the cath lab happen, and then one happens in the ED, another one happens in the OR, one is on the floor, one might be in your waiting room area. You have no idea. So when you start building any of these processes, along with all of the tools needed, you just need to make sure that you're teaching everyone around you how that would look. So another question I have for all of you is, if you have a hospital that is just starting to plan this ECPR program, they're really excited about it, you're hearing about it just like you are on this call across many different guides, what advice would you give them to start planning that? Is there something other than, maybe something I said or an avenue that you took that worked best for them to get to the next level? But what advice would you give them for that starting point? And that's really important to hear from you guys too, in that perspective and guidance, because you are the experts in that essence. I can say personally that, you can get all those ducks in a row, you can get the go ahead, you can build a great team, but if you do not have that education, I can't say it enough, education and simulation and, ability to work with everyone all around you, I think it'll probably fail, because you need to have all of that. The communication component is huge. And this goes beyond, again, that core ECLS team. This goes beyond your perfusion and your specialist team, your medical directors. It goes to your APPs. It goes to your bedside nurses, your RTs. It literally goes even to your housekeeping staff, because they have to come into a room that's probably covered in a lot of different blood products, just medicine everywhere. I mean, just, you wouldn't believe the mess that sometimes can be made. So just making sure that you're touching base with all of these units and all these teams within your hospital, and letting them know, hey, this is the approach we're taking. What about your biomed team? They have to service all of these systems and make sure that they're good to go. Can you take them outside of the hospital to the woods and put a patient on ECMO on there? Is that okay? So different things that you even have to have clearances for. If you're going to be using ambulance service and helicopter service, do you need to do education and simulation with them and include them? We did that at WVU. We worked with another outside facility. We had them cannulate. We came and picked the patient up, and then we brought them in. But I mean, just even the communication part of it, of our hospital leaving to go retrieve the patient and put them on ECMO, and how the patient was during the entire, ride to the hospital or your flight to the hospital. Are they still okay? Are they still a viable candidate? Giving the opportunity for the perfusionist or specialist that's going to collect the patient to really run that show and communicate effectively back to their home hospital, making the calls, this patient is no longer a candidate. This patient has been down for this amount of time, which is out of our patient criteria, and giving them the ability to make that call or bring the patient back if they feel that that patient would be back, while communicating with the medical team at their home hospital. And then again, you always have to include the administration around there, because You know, you always hate to say it because you don't want to ever think this way, but the budgeting component is huge, and being able to pay for that education and have all of those working parts that can be there to supply that and support it full throttle is huge. And you want to make sure that you have that buy-in, because if you don't have that buy-in from administration for that full support, that education could be done poorly. It could flop. So, you know, you could have the team, you could have everything else, but you just need to make sure that that is budget friendly for you as well. I can't stress enough at the fact that when I just even started looking this up, all of the research that was populating, which was really nice to see. And there's different, you know, approaches to look at research, but it was a lot of fun in my perspective, where we're seeing obviously all of the great things that ECPR is doing. We're looking at the difference between ECPR versus just conventional CPR for those out of hospital cardiac arrests. We're looking at the challenges. So is it a life-saving component? Is it resource wasting? Are we just putting anyone on when we probably shouldn't be putting patients on? Are we giving family false hope? And then at the same token, are we doing all of this stuff so that when a patient does leave the hospital, they're faced with all of these bills and we're not even thinking about that as well? How about the psych component of it? If they do survive this, how can we help them moving forward as a survivorship capability? What about the clinicians and them experiencing their barriers? I think that a lot of people tend to forget that component too, of accepting a patient and not accepting a patient. I can't imagine being in that era and trying to think, you know, if I put this patient on, that only leaves us with 2 systems available. You know, and if this kid needs it or if that person needs it, are we going to be able to put them on? So different surveys to look at in that essence. Again, that cost analysis and effectiveness modeling study, all of those are great. The feasibility, and again, that emerging technology like the Lucas device. I know it's been out for several years, but honestly, that's huge that we can do, you know, the same style of chest compressions with a device so that we can properly cannulate, but still providing that blood flow to the patient, especially for the brain to get that. And then technology is emerging. We have different things that are coming out that can also help with that out of hospital cardiac arrest, like balloon occlusion in the aorta, so that we can get blood flow to those areas that are really in need. But these all take part, all these studies, all these stories that you all have are huge. This story with the, I believe it was Minnesota team that had started their ECMO program. There was a husband at home that had collapsed. The wife, who was a nurse, started chest compressions on her husband right away. This doctor was just starting this ECPR program. He had to make the call. The patient had been down already for 19 minutes receiving ECPR. He decided to put the patient on ECMO, take them back to the facility, and that patient survived. And the story behind it all in this article, which I highly recommend reading, it was in the New York Times, was absolutely phenomenal. And he had a lot of other stories that were great positive stories. And even though it might not be as good of an outcome, these are the stories that we can take. These are the lessons that we can take to provide that motivation and be able to be behind what we're capable of doing from a healthcare perspective. We all got into this field for a reason, and we all want to continue to grow with this field as we're in it. So, you know, hearing stories such as this that they were doing in Minnesota and the wonderful things that I'm sure Justin is going to share with us next, make it all worthwhile even more so to want to continue to evolve with this practice of ECPR. With that being said, Miss Grayson or anyone else out there, any questions or anything that was brought up during that quick little spiel?
We don't have anything in the chat just yet.
Perfecto. Thank you so much. We will move on then to Justin Henson. Justin, if you want to introduce yourself, give a little bio, all the fun things.
My screen, camera's faced the other direction for some reason. Anyway, I'll just turn it off. Thanks, Jamie. My name is Justin. I'm the ECMO coordinator down in Albuquerque, New Mexico. I've been an ECMO specialist since 2016. I was per diem for a little while and then went to a full-time specialist, and then recently, well, I guess sort of recently, the ECMO coordinator in 2021. Throughout my journey, I've we started with a very small program and kind of evolved into what I think is a pretty busy program, especially with our ECPR starting in 2017 and our pre-hospital ECMO program starting in 2019. So it's been an excellent journey. I want to make a big shout out to Dr. Marinero. Some of this stuff is definitely driven by his experience and his creativeness to save people's lives in New Mexico, and to my ECMO specialist team, who are very, very excellent at what they do. So I have 20 slides prepared for you guys to talk about the ECPR program here at University of New Mexico Hospital. That's my disclosure. A lot of my experience is down here in the desert. I'm sure that there are plenty of ECPR programs out there that work very differently, use different machines, different hours, different things, like different people who cannulate. I would love to hear your guys' stories and how your programs work. Next slide. So let's start off with the definition of ECPR. The idea of ECPR is the transition of chest compressions to ECMO blood flow. So what I have here is a video of active rapid deployment of ECMO during CPR. What's really great about this video is the use of the Lucas device. Whenever we're using ECMO during cardiac arrest, it's important that the Lucas device or the chest compressor does not stop chest compressions, only when the cannulator asks them to pause. So you'll see in this short video that it is paused periodically so that, you know, wires and dilators and things can be threaded up through the femoral vein and femoral artery. Most often this occurs in the emergency room. Obviously this can happen anywhere in the hospital, in the ICU, or in a pre-hospital case. The picture on the right there is our pre-hospital ECMO team deploying ECMO in an ambulance at a scene call, which we've been able to do and very lucky to be able to do here in New Mexico. So here in, yeah, we can do the next slide. That was good. Thank you.
No, you're welcome. I can keep playing it if you wanted to see the rest of the video.
I really just wanted everybody to see that the ECMO was happening during the Lucas device. So here we're handing up the lines and then we connect the ECMO circuit and we go on. So the idea there is that while active chest compressions and the BVM and ACLS are happening in the background, the cannulator is putting the patient on ECMO so we can take over the chest compressions, the BVM, with the ECMO machine, the blood flow, and the sweep gas. So at its very foundation, VA ECMO in general, not just ECPR, the idea is to drain blood from a vein, particularly the femoral vein, and we're going to drain that blood into the centrifugal pump, send it through the oxygenator, and then send it up the femoral artery, up into the aorta in a retrograde fashion. One thing that is important to know about ECPR is, and ECMO in general, obviously, is that it's a bridge to something, right? So looking at inclusion criteria in different facilities, I think it's important to see what other people are doing, what age groups they're using, what weight limits they're using, what kind of arrests they're putting people on. At UNMH, we use an age limit of 75 years old or less. We like, obviously, you want to know that the cardiac arrest was witnessed, right? It's interesting to see video footage of cardiac arrests happening in the real world and how many times the bystanders don't do CPR. So not only is it a witnessed arrest, but was there bystander CPR within 5 minutes of the arrest? Another interesting thing that I learned in the last couple of years as well is in the community, when people call 911 and the dispatcher asks if the person there is breathing, what the person is actually doing is agonally breathing. And agonal breathing is a natural response to cardiac arrest. Is it actual breathing? It is not. But for somebody in the community to say, yes, they are breathing, those are some things that can be missed in the story. They could be breathing like that for 10, 15 minutes before they stop altogether. And so that can really change the outcome for that patient. Another important thing to notice in the inclusion criteria here is the VFib, VTAC arrests, the shockable rhythms are the really, really good arrests when you think about ECPR and survival to discharge. We do quite a few PEA, and obviously, yes, we've done asystole in the past as well. End-tidal CO2 greater than 10, for those of you that don't know, that is an indication of high quality CPR. Appropriate depth, appropriate rate, minimal interruptions. You should have an end-tidal greater than 10. If you don't, or for some reason EMS is bringing the patient into the EDRU or the emergency room, whatever you call it at your hospital, and the EMT is doing chest compressions to the sidearm CPR, you're not going to have a great end-tidal, you're not going to have high quality CPR, and that patient is probably not going to survive to discharge. Presumed cardiac cause is very important as well. I think that when you think of the telltale sign of cardiac arrest in the community, you have somebody that says, my chest is hurting, or I feel like there's an elephant on my chest, and then they grab their chest and they collapse. That is a perfect example of a presumed cardiac cause of arrest. If you think about a presumed respiratory cause of arrest, you could think of an accidental OD, an intentional OD, and all of those things are precluded with hypoxia, extreme hypoxia, before cardiac arrest. So what you don't want to do is put the patients on that have respiratory arrests, and you do want to put the patients on that have a good story that points to a presumed cardiac cause of arrest. Can you put the patient on ECMO support within 60 minutes is huge. Have we down here put someone on at 61 minutes? Absolutely. 59 minutes? Absolutely. 17 minutes? Absolutely. All different ranges, but we absolutely need to stick around the hour mark. After an hour, the chance to survive to discharge with ECMO or not is extremely slim. The stuttering, unless it's a stuttering arrest, on the last bullet there, we look for signs of life. Those things are breathing, gasping, pupillary response, and then localizing. Localizing is huge. In my experience as a bedside nurse, ICU nurse, there are many times I can remember seeing people localize or try to rip the Lucas off their chest when chest compressions are actually happening. And then when the chest compressions stop, they go limp and unresponsive again. So for localizing movements, even if the patient has a weird story, let's say their end-tidal was 8 or it's 62 minutes of arrest, if that person still tries to localize, that person's going on ECMO. That's a great sign, and that is a positive, that could be a positive outcome for that person. Hypothermic arrests are very different. When the patients are cold, their metabolism is slowed, their brain function is preserved, they can arrest for a lot longer than 60 minutes. I can remember a kid arresting for 3.5 hours, going to 3 different hospitals, finally made it to UNM hospital. We put him on ECMO, warmed him up, and he made it out of the hospital about a week later. Time is of the essence, but if they are cold, you have a lot more time to consider these patients for ECMO. Next slide, please. So exclusion criteria. I think one that most hospitals agree upon are end-stage organ disease. For example, someone who's Monday, Wednesday, Friday dialysis, not really a transplant candidate, has AV fistulas. Somebody who if you're calculating a MELD score for liver cirrhosis on somebody, they're not an ECMO candidate here. And I would assume that it would be the same for most programs. Cancer is really, you really have to think hard about cancer. Now, for example, let's think of somebody who has stage 3, stage 4 cancer. They've been told they have about 6 months to a year to live. For example, they come into your hospital with a massive PE. Totally, their quality of life at the moment is fine, and they do want to live. If you put somebody on for a massive PE with cancer, you're looking at maybe 2 days on ECMO if you have a hospital that's going to do a thrombectomy on this person. So in certain scenarios, cancer is not really 100% no. It's what are they coming in for? What's wrong with them? Can we bridge them to allow them to live another 6 months or a year? And I don't know about you guys, but in my current state in life, I would absolutely take another 6 months or a year for some silly PE. Morbid obesity, That's a loose one as well, very relative exclusion criteria. I think that when it comes to being too big or too small, it becomes logistical. Can you safely insert ECMO cannulas in these patients? Can you safely maintain these cannulas in these patients? You're looking at very obese patients where they may not have a groin to get to without, having to get 4 or 5 people in there to lift the belly up. That's not great, right? You may have very obese patients who don't really have a great neck access for an IJ cannula, for example, maybe VV ECMO. They really are at risk for those cannulas coming out as well because you can't see them. So morbid obesity to me and being too small is all logistical. You definitely don't want congestive heart failure patients, the ones that come in, they hate doctors, they don't take their Lasix, they're very swollen, they have the nasty, creepy, crusty toes. Those aren't the people you want to put on ECMO. What you want are the acute reversible heart failure patients, maybe like the postpartum cardiomyopathy women or myocarditis, acute myocarditis. And then another one we look at for ECPR specifically is the groin access. Obviously with ECPR and rapid deployment of ECMO during cardiac arrest, you gotta put the cannulas in quickly and you have to use the groin. And if you can't use the groin, then they can't be a candidate for ECMO. So that one's very important. Next slide, please. So let's just go back to what the goals of ECPR are. And you can think of it as VA ECMO in general. What we need to do is put them on ECMO during their cardiac arrest and bridge them to heart recovery. During that time, while we're waiting to recover the heart, we need to clear their lactate within 24 hours. If you clear their lactate within 24 hours, you're increasing their chance to survive to discharge. While you're clearing their lactate, you're increasing perfusion to the brain, the heart, the coronary arteries, everything else. While you're doing that, you're preparing a plan. Was this a STEMI? Well, let's go to cath lab and do a PCI, right? Let's stent. Let's balloon their coronary arteries. Let's figure out where the insult came from. PE patients, let's put them on the agenda to get a thrombectomy in the next couple of days. Hypothermia patients, let's warm them up to 28 degrees. Most patients who are cold are going to be in VFib. When they're in VFib, their heart really doesn't respond to shocking until they're a little bit warmer. A lot of our experience with hypothermia here, believe it or not, in the desert, it gets really cold at night. And our experience with hypothermia is these patients come in around 20 degrees Celsius. So our goal there is to immediately warm them up to 28 degrees as fast as we can, because no one is dead unless they're warm and dead. So you warm them up, you shock them out of their VFib, and then you slowly rewarm them to normothermia. Those patients typically have a really rapid turnaround with about 12 to 36 hours. Another goal of ECPR is we should determine whether these patients need cardiac surgery. Is there a surgeon willing to do cardiac surgery, or do we need to send them somewhere for cardiac transplant? At the University of New Mexico, we do not have a transplant program. I think the only thing we do are kidneys. So for these patients, we start calling around the region and send those patients out pretty quick on ECMO. Cannulation strategies. Obviously for ECPR, we're looking at femoral cannulation. Femoral cannulation to me is peripheral. We're looking at the groin area. One of the things that our doctors like to do is use the same side in the groin. If you use the same side femoral vein, femoral artery, you decrease the amount of possible cannulation complications such as accidental AA, accidental VV. So if you're really looking to reduce any complications or avoid them altogether, the same side cannulation in the femoral sites is a great way to go. For central cannulation for VA ECMO, it's typically not ECPR. Sometimes it may be, but these patients are typically on bypass already and they're being supported by a bypass device. But really focusing on the groin is what you need to cannulate during ECPR, and all you really need is someone who can do TEE and somebody who knows how to use an ultrasound to find vessels in the groin. If you are a cannulator or you know somebody who's interested in cannulating, I think that one of the considerations for ECPR is they have to know that these patients are receiving high quality CPR to even be considered. High quality CPR is the very basic foundation of a very successful ECPR program. If you cannot achieve good quality CPR, your patients are not going to survive often. You got to listen to the background. When EMS brings these patients to the ED, the cannulator needs to listen to the story. They need to know that this was witnessed. They need to know that someone did chest compressions. They need to know any history the patient may or may not have. Cannula size. We make it easy at UNMH, and we use 13 French arterial or 15 French arterial. 13 French arterial we've been using in the last couple of years. It definitely decreases the need for reperfusion cannula placement, and it's great for smaller patients than are, I would say, you know, maybe most women, maybe smaller adults. 13 Frenches are great. 15 Frenches traditionally for us have been our go-to. And what we use for our drainage cannulas is pretty easy as well. We use 23 French multi-stage or 25 French multi-stage. That really gets us the flow that we need. We're looking at maybe anywhere from 4 to 5.5 liters that we need for these patients. TEE, does somebody in the ED know how to do TEE? TEE is very important to find your wires during cannulation. If you're using the same side or you're using bilateral femoral vein, femoral artery, you need to know where your wires are going. You do not want to have wire injuries. You're trying to save someone's life, not prolong their death. And you also want to make sure you're not cannulating them AA or VV on accident. And then also having the availability of heparin in that area is important for the 5,000, 2,500, 7,500 bolus that they need during cannulation. Next slide. So this, I cannot take credit for this. This has helped me tremendously in my experience as an ECMO specialist. And I teach this to all of my ECMO specialists. The person who, Jamie Schaffer, was my mentor for several years before I became a coordinator, and she taught me this mnemonic. It's called HOPCAT. So you could take this to your program. It's everything you need in an emergency for ECPR. There's so much going on. You may have a controlled environment. You may have a chaotic environment. You may not be able to hear. But if you can reference HOPCAT, you'll know everything that you need to put this patient on ECMO. H is for the heparin bolus. When you get in the room with your circuit, you're thinking about, does someone have heparin drawn up? So if not, you can shout it out. Oxygen. So oxygen to me is making sure that the tank is full and that the oxygen tubing is connected to your oxygenator. You don't want to be the guy that starts the ECMO device and the oxygen wasn't on. P is for power, plugging in your device to the wall. Our heaters do not work without power. You don't want to sit in the ER for an hour and not be plugged into power. You're going to drain your battery. So plugging into power is very important. C is a lot of different things. C makes me think about grabbing the cannulas for the cannulator, clamping the ECMO circuit, because you want to be the last clamp to come off before ECMO flow is established. The physicians can take their clamps off when they're ready, but you are the last clamp, and that's very important. Making sure all your connections are tight on your high flow stopcocks, on your manifolds, your bridges, whatever you use. You don't want a connection to blow off while you're trying to save someone's life. And then CO2. CO2 to me is turning the sweep on at a very low rate pre-ECMO, and it's also thinking about what is the current end tidal on the monitor. There's been several instances where I've looked up, saw an end tidal of 6. I've told the cannulator the end tidal is 6. It hasn't really changed. And that has really been the deciding factor between doing ECMO versus not doing ECMO. A is for air. So making sure that when your pump is spinning, when your clamp's not on there, that there's no air bubbles circulating. And then the last one is T for temperature. So getting your heater cooler ready and on and warm for hypothermic patients, or while you're standing there waiting for the cannulator to place the cannulas, you can fill your heater up with water, get it connected to your oxygenator, and start the prime. When we get these patients on ECMO, what we really want to focus on, again, is clearing their lactate and perfusing their organs. We're looking at a map of 65 or greater. We're looking at trying to get enough blood flow, whether that's 4, 5, 5.5, 6, if they'll let you, to clear that lactate. In the beginning of your ECPR, you want to do 1-to-1 with your sweep gas. So if you're going to go on 4 liters of blood flow right away, let's do 4 liters of sweep. If they've been arresting for 50 minutes, 4 liters is probably not enough, but it's a great place to start without having to guess. FDO2, when you get your first couple of blood gases on these patients, they're going to be very hyperoxygenated. Typically, their heart is not beating, so the ECMO flow is reaching all corners of the patient's body. And those of you that know the oxygen content of an ECMO circuit, it can be anywhere from 200 to 400. And you definitely do not want to hyperoxygenate these patients for very long. After you put these patients on and you get them stable, you need to start thinking about assessing their lower extremities. We want to be able to prevent limb ischemia in these patients. You don't want them to die from a dead leg when you just saved their life from cardiac arrest. Thinking about your NIRS oximetry, looking at their head and trying to spot differential hypoxia, putting them on the legs so that it can help you find limb ischemia. And then also in the back of your mind, in the ER especially, is you're going to have to start transporting somewhere, whether that's to CT, cath lab, OR, wherever. At UNM, we typically go to CT right after cannulation, and we look for CPR injuries like liver lax, splenic lax, pulmonary contusions, cardiac tamponade, all types of things. And then during that CT scan, we also scan all the way down to the mid-thigh so that we can visualize blood flow going past the cannula to the leg and the foot so that we know we are perfusing the foot. Next slide, please. So you get these patients on, and what you're going to start thinking about and looking for are complications. VA complications in general are listed here in the next couple of slides. Most of the VA ECMO we do at UNM is ECPR, and so we're thinking about a lot of these things very consistently. So the first one we're going to talk about is the laminar arterial line. Most patients who have been arresting for 20, 40, 60 minutes, when you put them on ECMO, they're not just going to magically be pulsatile again. So if you see a flat art line, you're looking at the map. That's what really matters to you, is you want to make sure you're perfusing the body. Even if the patient's heart is not beating, you're generating a pressure with your laminar flow from your ECMO circuit, and you want that map to be normal. The bad part about a flat art line is you should not be okay with it for very long. If you're in the ER, you can be okay with it, but if you're in the ICU and it's 2, 3, 4 hours since you've established blood flow and you're still flat, you've got to start thinking about these problems that can occur. If you leave an art line flat and untreated, you're looking at ballooning the LV to a massive size. And if it gets big enough, it's going to collapse the RV and you're not going to be able to flow. You're thinking about intracardiac thrombosis. What happens to blood that doesn't move, blood that doesn't leave the LV? If the aortic valve is completely closed and is not opening, you're putting your patient at risk for clotting in their LV, in their pulmonary vasculature, in the RV, all those places. And then the last one, which I've had a lot of experience with, and it is terrible, is pulmonary hemorrhage. So if you think about the blood that's not moving throughout the central circulation of these patients when their hearts aren't beating, you can imagine how much pressure builds up in the lungs. At a certain point, the alveolar capillary membrane is going to rupture and you're going to bleed into your lungs. I'm not talking about, fluid overload, pink frothy. I'm talking about actual frank blood spilling out of the ET tube to the point where you actually have to clamp it. So flat art lines are okay for a little while, but they are absolutely not okay in the long term. What you really want here is you want a pulse pressure. For those of you that don't know what a pulse pressure is, if you subtract the systolic blood pressure to the diastolic blood pressure, you want that number to be somewhere between 8 and 12. If it's between 8 and 12, you can feel confident enough that the LV is emptying the blood that is in it. The aortic valve is opening just enough so that the blood can escape. The treatment for flat art lines, non-pulsatile hearts, first line is an epinephrine drip. You want to start that off at a low dose and try to elicit some kind of contractility, some kind of pulse pressure in these patients. That's the easiest thing you can do in an ER scenario. Further on down the line, if the contractility inducing medications don't work, you can start thinking about how you're going to vent the LV, aka empty it. And at UNM, we have the ability to rapidly place Impellas in the cath lab. If this patient was a STEMI and you're going to the cath lab anyway, awesome. You can assess the need for an LV vent when you're there. We've actually had a patient who had an aorta that was too small for an Impella, believe that or not. So we've had to resort to putting in a balloon pump on that person. So those are some things to think about when you see flat art lines. It is not okay in the long term. So this is just a close-up picture of what an Impella does. An Impella is placed in the femoral artery. It's threaded up the aorta and into the LV. And what it does is it physically drains blood out of the LV, bypasses the aortic valve, and shoots that blood into the aorta. Absolutely perfect for what we need it to do on ECMO. Now you have something that will vent your LV, and now you have something that you can bridge to from ECMO. So perfect. Another complication to think about with VA ECMO in general, but specifically ECPR patients, is differential hypoxia. Differential hypoxia is deoxygenated, poor content blood coming out of the LV when the patient becomes pulsatile again. Now, in the beginning, the patients aren't pulsatile. They have a flat art line. Their whole body is getting this amazing ECMO blood flow that has a PaO2 of 300. So what do we do as clinical specialists? We turn the vent down from 100% to whatever, 30, right? We turn the FDO2 down on the ECMO circuit from 100% to, whatever, 80, for example. When the patient becomes pulsatile again, and if for some reason that blood coming out is hypoxic, the first place it's going to go is to the coronary arteries. It's going to make the heart angry. The second place it's going to go is to the brachiocephalic artery, which feeds the right upper arm and the right carotid artery. So you can imagine that now the coronary arteries are getting deoxygenated blood and the right side of the brain. And if the patient's heart is beating hard enough, you could have deoxygenated blood feeding all of the upper body. And in extreme scenarios and cases, the patient will be discolored in the upper half and perfused in the lower half. Now, to have this issue, you have to be on VA ECMO, peripherally cannulated, to find it. You have to have sick lungs. So if you think about why the blood is coming out like this, it's because the lungs are sick. Maybe they aspirated during their arrest. Maybe we're under oxygenating them with the ventilator or under ventilating them with the ventilator. Maybe they have a really nasty pulmonary contusion from the Lucas device. So many different things to think about. Maybe their art line was flat for too long and they're bleeding in their lungs. So that's how we find out. And so the first place you're going to find this issue is in a right radial arterial line. These ECPR patients that are obviously peripherally cannulated, they should have right radial art lines, obviously in their upper extremity, because you want to be able to spot differential hypoxia at its earliest. And you're going to spot it at its earliest because the first artery off the aorta is the brachiocephalic artery, which feeds the right arm. So if you have differential hypoxia, the first place you're going to see it is on that blood gas on that right radial art line. NIRS on the forehead. If you don't know what NIRS are, it's cerebral oximetry. We have a monitor that we can use to place stickers on the right side of the forehead and the left, and this helps us spot differential hypoxia without having to draw any blood. So if you're feeding the right upper arm hypoxic blood, and the left upper arm is getting great blood, you're going to see a really low cerebral oximetry reading on the right forehead and a normal one on the left forehead. Another thing to consider as well for easy determination of this issue is your SAT probe. We should probably try to put those on the right hand or somewhere on the head. How do we treat this issue? So once you've spotted it, the first thing you should do is use your ventilator. The problem, this is caused by one problem, sick lungs, right? These patients are typically intubated, so let's use the ventilator to try to correct this issue. You can increase the PEEP. You can go from 5 to 8 or 8 to 10 or 10 to 12. You can increase the FiO2 back up to 100% because we turned it down to 30 earlier. That usually fixes this issue. If that doesn't work, what you need to consider next is moving the mixing cloud in the aorta, where the patient's blood flow and the ECMO meet, move it closer to the aortic valve. Turn your blood flow up on your ECMO device. The last thing you can consider is adding a third cannula. You can add another drain to drain out more blood of the patient's body, or you can add another return. It gets really dicey there, really nasty, hard to maintain. But if it becomes such a serious issue where you can't just transition to VV because the heart's still not well enough yet, you have to add a third cannula. And our experience with that down here is very dicey. So another complication to think about with ECPR and VA ECMO in general, peripheral cannulation, is limb ischemia. So down at UNM Hospital, we don't prophylactically place reperfusion cannulas. You might think we're crazy, and that's fine. I like that we do some things differently. So reperfusion cannulas are considered on a case-by-case basis for us. What we do to spot limb ischemia early is we do Q1 hour neurovascular checks with the bedside nurses and with the ECMO cannulator. At baseline, we're flexing the ankle. We're pushing up on their feet bilateral just to see if there's any baseline muscle stiffness or to see how flexible they are. The first sign of dead tissue is a stiff muscle. And so if you're starting off stiff, at least you know as a baseline assessment, I'm starting off stiff. If you started off very flexible and the muscle and the calf muscles feel great, you don't have any tight compartments, then if it becomes stiff in the future, you know right away you have a problem. So part of that neurovascular check is ankle and calf stiffness, cap refill, pulses, and temperature of the lower extremities. I talked about the CT scans that we do for these patients. Part of our CT algorithm is to scan mid-thigh so that we can see blood flow flowing to that foot that has the arterial cannula in it. Not in the foot, but the same leg. So how do we treat limb ischemia if it's spotted? To me, if you have poor cap refill in the leg with the arterial cannula and excellent cap refill in the other, that is sign enough for limb ischemia. Don't wait for the pulses to go away. Don't wait for the temperature to get cold. Don't wait for the muscle to get stiff. Talk about it. So reperfusion cannulas are placed in the SFA, superior femoral artery, and they're facing the opposite direction of the arterial cannula. So what we're doing is we're stealing a little bit of blood flow, and typically it's about 200 mils per minute from the arterial cannula there in that bottom picture, and we're shooting it into a 6 or 8 French sheath that feeds the foot. If you leave this issue untreated, it makes sense. We're looking at increased mortality risk, amputation of the affected extremity, and multi-organ failure from lactic acidosis, buildup of K. It just gets very nasty. So a little bit about anticoagulation here at our center. Everybody does heparin differently or bivalve. Oh my goodness, it is like half and half all the time. No one can agree on anything, so I understand that. What we do here is we do one ACT, sometimes a couple, but what we're looking for is an ACT of less than 250 seconds. When we see that, we know that our bolus is wearing off from cannulation, and we should start thinking about starting a heparin drip. In certain scenarios, we do delay heparin drips, even if the ACT is lower, if we're going to cath lab for PCI. In cath lab, they get heparin boluses, they get ticagrelor, they get aspirin. So no need to start a heparin drip when they're getting all of that already, because all you're doing is putting your patient at risk for bleeding complications. So what we use here is a subtherapeutic and therapeutic range of heparin, and we monitor PTT values. So a subtherapeutic range is a PTT from 40 to 59. That's really reserved for patients who have mild to moderate bleeding and just VV ECMO patients in general, because they're flowing a lot higher than VA ECMO patients. Therapeutic anticoagulation is for most people that have no bleeding complications or signs of bleeding. No anticoagulation is very, very reserved for severe bleeding issues, such as intracranial bleeding or maybe GI bleeding or some kind of lac from CPR, like a liver lac or a splenic lac. We definitely will not be giving those patients heparin right away. And then we use subcutaneous heparin a lot for our VV ECMO patients, especially those that are flowing around 6 to 7 liters. Sometimes that's all they get. Weaning and decannulation. ECPR patients in general, their runs on average are about 3 to 5 days. You know, giving time for cath lab, PCI, heart recovery, thrombectomy, consideration for cardiac surgery, or transport out of the hospital. So we use a couple of strategies here for weaning and decannulation. Patients at our hospital are decannulated by the vascular surgeons. Sometimes we decannulate patients at the bedside if they have a 13 French arterial cannula, and we hold pressure for about 30 minutes to an hour. So one of the strategies to wean is a clamp trial, and this is really for patients that are already anticoagulated. You really want them to be when you start weaning. First off, we don't even try to do an echo until we're about 2 liters of blood flow. So we'll get to about 2 liters of blood flow on the ECMO device, and then we'll get the TEE machine at the bedside, put the probe in, and then every couple of minutes we're lowering our flows, and then we're gonna clamp at the very lowest. And in that moment, we're looking at LV distension, RV distension, and just poor function in general. We're looking at whether the nurse has to increase pressors or not. If we do it for long enough, we might clamp for 2 minutes, let it flow, clamp for 2 more minutes. We'll check a lactate. Another strategy we use, which is kind of fun, you really got to convince your doctors to like this, but it's called a pump controlled retrograde trial. What you're doing here is you're slowly decreasing your RPMs on these patients. Obviously, these patients are better. They've got good pulse pressures, minimal pressors, things like that. You're slowly decreasing the RPMs on your device until you get a negative blood flow reading on it. You can also, if it has an external flow probe, you can flip the flow probe opposite direction. And you're looking for about 500 to a liter in a negative retrograde fashion. You can do this for a lot longer than 2 minutes. And so that's what's nice about it. Typically, I don't think we've gone past 20 minutes doing this strategy, and some patients will even let you flow negative a lot more than that. If these patients can pump blood through their body and backwards through an ECMO machine and not increase their pressors and not have a rising lactate, what more information do you need to take these patients off, right? Next slide, please. So some considerations for ECPR programs. I think like at its very foundation, what you need is a facility that consistently does high quality CPR. In title, greater than 10, adequate chest compressions, minimal interruptions, shocking as soon as possible, all of that. I think it really, really contributes to that 31% chance to survival. If we did not have high quality CPR, we would not have great outcomes with these patients. The Lucas device has been very instrumental in Albuquerque. We've been able to get a Lucas device to most ambulance companies to where, and they kind of pre-triage these patients as well as ECMO candidates. We'll slap them on a Lucas device, and instead of working them at the scene, put the Lucas on and send them to UNM for ECPR. I think that's incredible. Immediate response time is important. You want to respond to these cardiac arrests within 5 minutes. That means the hospital has to pay for somebody to be available every day for this. I won't say that we're doing 24/7 ECPR coverage here. We actually don't. We have a free ECPR specialist Monday through Friday, 7 to 5. Anything after those hours is on call from home. So you have to have a system in place where an ECMO specialist who knows how to use the device or a perfusionist to respond immediately. You also have to have somebody that can cannulate immediately. Down here are ICU intensivists. They cannulate these patients. And about 80% of the time, there is always a cannulator at the hospital 24/7, whether they're on, the ECMO service, the trauma service, the medical ICU service, there's somebody around to put these patients on. Another good thing is a dispatch alert system. We use Tiger Connect here, and we use our dispatch center to send out alerts for specific patients, and those patients are cardiac arrest. The alert comes through as EMS cardiac arrest. It gives the age, usually whether it was witnessed or not, and the presenting rhythm. And we can triage those pages from dispatch whether we're going to show up immediately or we're going to wait on standby for those. Post-cannulation and management systems. Having a good CT scan power plan is excellent. You want to look for CPR injuries, immediate signs of brain anoxia, flow to the feet on the arterial cannula side, all those things. You want to have a cath lab, right? You want someone who's going to be able to balloon these coronary arteries or stent them or place impellas or balloon pumps for LV venting. You want to have cardiac surgery or surgeon in general that's comfortable with assessing these patients for the need of cardiac surgery. And then for decannulation, you want to have a system in place with vascular surgery to get these patients removed from ECMO safely and not have bleeding complications afterwards. Education. Education doesn't, it's not a group of people who do ECMO that get all this education. The ER staff, they know how to do awesome CPR and ACLS, and they have a great system down where the nurse runs the whole code with the direction of a physician who's at the head of the bed that's also managing the airway, and it's quiet, it's smooth, it is just perfect. So I actually think that RNs run codes a lot better than physicians do, but I understand that physicians need experience as well. But the education doesn't stop in the ER. It goes to the CT scan people. They have no idea what these ECMO devices are, how dangerous they are if they're sloppy with the table, right? They could accidentally rip a cannula out without even knowing how serious it is. Like educating people in the hospital about what ECMO is, how your program works, is only going to make your program better. Next slide, please. So really, that's all I have. I will say that since our ECPR program started in 2017, I've had the time of my life learning so much and saving lives with my group. And I know that in the beginning, the hospital was very reluctant to start this program as far as paying for it. And I think for 6 months, we had one of our doctors responding to every single cardiac arrest in the ER for free to collect data on the patients that he possibly could have saved with an ECPR program. And so if you guys are ever interested in starting one at your hospital, or you want more information about how to start a program, this is the spot, ECLS 360. You guys can always email me as well, and I'm happy to respond. Thank you.
Thank you so much, Justin. That was amazing. And that picture of that little peanut's just so cute. And the Homer Simpson, I'm not gonna lie, it definitely made me chuckle out loud.
Yeah.
That's a good one. Always those pictures always bring everyone back in. There were a couple of questions put in the chat. I don't know. Let me see if you're able to touch on them quickly.
Sure. Do you want me to read those for you?
Yeah, sure. Yeah, that works because I can't do a pop out. I'm sorry.
No problem. So Justin, thanks for a great talk. We really appreciated it. We had a few comments here. So one was from Christine Zachariah, and she was curious if you guys are still hand cranking if you do cannulate folks out in the field. So could you speak to that a little bit, what you guys used to do with a crank mill and whether or not you're still doing that now?
Yeah, thanks for the question. Yes, traditionally we were doing, we used the Rotoflow device, and in the hospital, we always have a ready to go ECPR circuit set up. We also have an ambulance that we put a circuit in to respond to pre-hospital ECMO. So we are still doing that. We actually had a case 2 weeks ago. He did not survive, unfortunately. But now we are bringing the ECMO specialist in the ambulance and the console, the Rotoflow console. So we've made 2 changes since 2019 to try to get a survivor, and that is adding an ECMO specialist to the ride and putting a console in there. So no more hand cranking for now, but I mean, yeah, that was a lot of fun. I'm not gonna lie.
Sure.
Have you had any more success doing that, or are the jury's still out yet with putting a specialist in the ambulance?
I think our N equals 9. With our city is very spread out. We don't have a lot of per capita people all in one area. Very spread out, very hard. The guy we went to go cannulate the other day, we put him on at 57 minutes because he was 30 minutes away from us as far as the drive. So I think we struggle with that, and we struggle with the perfect VFib BTAC candidates. You know, getting the story is always hard. You know, I think for the previous 8 patients, there was always something about the story popping up later where we were like, oh yeah, we probably shouldn't have gone to that one. You know, so it's very, very hard to find those people, but we are still doing it and we're very optimistic still.
That's great. And I know Dr. Marnar is very passionate about it, and that you guys are doing a lot of good out there. So thanks for sharing. We had one other comment from Rachel, who's out in Minnesota. So Rachel was commenting on Jamie's part of the presentation, and she said that along with education is feedback to the EMS team that brought the patient in, or the ED team that was part of the cannulation, sharing the successes and also the struggles. So I know that that's part of what you do with all of your ECMO patients at WVU, Jamie and David, but do you want to speak a little bit to that about the follow-up that you guys do with your patients?
Yeah, so even from a unit-based perspective, we started having ECMO touch-base meetings and working group meetings, which we've always had, but we're including all of those teams now. And Alan, who actually is the new ECMO coordinator at WVU, is on the call too, so he can speak to this as well if he would like. But we invite all of those groups to join on, and we recently started talking about our cases and the case studies more from like an M&M perspective, but also just as a team to see where we can improve upon. So providing those wins, because a lot of those patients, like you had said, Rachel, you know, the service drops them off and then they leave and they don't really get to hear anything past that unless they have a, you know, an in, I put that with the, the quotations, that they can hear more from, or if they stop by with another patient, they just happen to ask questions. But with that being said, we always try to keep everyone in the loop, because I'm sure that there are things that they would like to learn from as well, not even just from the hospital base, but like you had said, the outside teams. And I don't know, Justin, Henson, if you have anything to add to that with how you keep everyone in the knowledge base with your AMBU crew and whatnot.
Yeah, the follow-up is it's very difficult to come back and figure out the, you know, who was there, because it's always a different crew. So we definitely struggle with that. I know that we have a physician who is a liaison between our ECMO program and the EMS consortium doctors. He's very, very involved in ECPR and pre-hospital ECMO. And so he does most of the relaying of successes and, you know, close ones and things like that. So very grateful to him for that, because he knows everybody on both sides. You know, I think that's a little bit of a barrier.
Yeah, and it's awesome when you get to share those wins with all of the teams. So I think that's something to really even consider and think about, even from my, you know, stance and whatnot, to make sure that we are sharing all of that with everyone that did participate, like you said, Justin, because it's hard to get a hold of everybody also at times too. So I know that I would like to learn more from anything that we had done. So even from just bedside cannulations and sharing that information. Sometimes they do a lot of little debriefing right after cannulations too. I know on the outside, away from family if they're there. So that's always good to do, just to do like a brief, quick coverage of what happened, and you know, if there were any areas that any staff had questions on that you can touch base on quickly and then revisit later on. That's always something that's available. But
I think especially with ECPR, because it can be so disheartening, because like you said, Justin, an N of 9, and you keep doing this, you're working those extra hours, you're going out and doing these cases, which we all probably think are fun, but it is a lot of extra time and stress. So hearing when they do well, I think is just as important as getting the feedback on how we can do things better. So we had one other question here in the chat, Justin. So this is from Mohammed Khan, one of our ECMO specialists here at CCS, and he asked, what strategy do you follow to remove lactate from a patient with cerebral edema? So do you have any particular strategies that you can talk about for decreasing that lactate rapidly over that first 24 hours?
Mohammed, what's up, buddy? We miss you out here. You know, I don't have a whole lot of experience with clearing lactate in the setting of cerebral edema. I'm sure I have, right, without knowing, until that like 3-day, that 72-hour CT scan, right? But to me, Mohammed, I try to go as high on the blood flow on the ECMO device as I possibly can without making the map too high, right? If you're going to clear a lactate, you want to do it as fast and as aggressive as you possibly can do it. And to me, that means if I have a 15 French arterial cannula, I'm going to try to get to 5 if the circuit will let me, right? A lot of these ECPR patients have leaky vessels after arresting, right? So they need a lot of resuscitation. A lot of their fluid goes into their tissues. You can't flow as high as you want to. You can't clear the lactate as fast as you want to. And I think we really underplay how much resuscitation these patients need. So to me, the best case scenario for clearing lactate is get on ECPR, resuscitate them appropriately, and flow as high as you can until your lactate is less than 2. And hopefully that's within 24 hours.
Yeah, for sure. Flow, flow, flow. All right, guys, I don't see any other questions here.
Well, we have our next ECLS 360 webinar coming up on April 30th at 5 o'clock. We try to do these the last Wednesday of every month at 5 p.m. Eastern Standard Time. Our topic is to be announced, so please make sure to save the date and look for any announcements on LinkedIn or our other social media presence, Instagram, etc. And as always, we'll send emails out to all of you as well. But obviously, we're here for you in any capacity. Email us, let us know if there's anything we can do for you. Our Ask the Expert QR code is available. You can message us there. You can also message us on LinkedIn. We always try to respond. If you have a topic that you would like for us to present or something more that you would like to see, please let us know. We always want to make sure that we're touching base with all of you guys in all of those areas. But thank you so much again for attending. And yeah, we're excited to continue on with these webinars. Thanks, everybody. Thank you so much again, Justin. That was amazing. We genuinely appreciate you and all of your time that you gave us tonight.
Thanks for having me. Take care.
Thanks, everybody.
Thank you. Oh my God.